Morning or afternoon, everyone. Welcome back to today's open forum. Thank you, as always, for joining us virtually today. As you know, we have a no in-person audience in the support of physical distancing. And I'd like to open today's forum by revisiting our focus on respect and civility. I know this is a very challenging time for all of us, and it's normal to feel anxious, and sometimes it's normal for anxiety to bring out some behaviors that normally we wouldn't wish to exhibit. That's particularly true when we have fear of the unknown. But respect and civility are essential to our success through this, and a lack of it will only harm us, our Team UHN, and our patients. So I truly have to ask you to think about not only what you're saying, but how you're saying it, so we can really get the very best results and we keep lines of communication open. People who are tense and angry and still fulminating about the last nasty comment someone made to them don't make great teams. And I know right now it's tough, and I know there are times when we're all short of temper, but we have to be extra vigilant on not letting that come through, because it is at times like those that we will most need each other, and those kinds of comments and actions really make it difficult for the multidisciplinary team to be effective. So please continue to be mindful of that. We need to have each other's back now more than ever. This principle also extends to open forums, which were created to support the team in an open and transparent fashion. So I have removed a number of questions. This is not censorship. I want to be clear. I'll come back and I'll bring the questions back in a more civil form. But if your question is disrespectful or self-identifying or entirely unhelpful by making a comment that a person or a group is completely useless and we should get rid of them, it's neither helpful, respectful, nor consistent with UHN. So I apologize if you don't see those comments. You're not going to see them. We're not going to entertain those kinds of questions. They're not questions, mostly they're statements. And it's from a very small minority of people, but we're not going to reward that behavior, especially at a time like this. So I hope you'll forgive me, but I'm not going to entertain questions that are disrespectful of others. As I said, we'll keep those off to the side. We'll try to form them in a more civil manner and bring them back when COVID-19 is over and talk about the broader concepts. So thank you for that. I also do know that I want to remind you again of the resources that are available to you if you are feeling stressed. We've dealt with some of those here previously, but they are online, and please go to my UHN or go to the COVID page. You'll see more information. And of course, by my previous comments, I don't mean that you shouldn't be asking tough questions. I just mean you shouldn't be asking rude questions. Let me also move on to a number of gratitude opportunities. So I'm now going to pull up the gratitude page where so many of you have been kind and generous to each other and your colleagues. And here are some comments for you to observe. Some thanks to the digital leadership, the entire team, to the occupational health and safety team, to the allied health staff, to our executive team, to the staff being redeployed. A real shout out, I know that's stressful. To our respiratory therapists, and even a thank you to me, which you don't have to do that. It's a privilege for me to be here. Our PCC, absolutely, particularly Cheryl Toadley, I think, was one who was shouted out to by the MSICU, and so many more. So please go on and look at the page, and I hope many of you will also focus on offering some comments on that page. I'd encourage you to go on to the Slido page and again use hashtag #ThanksUHN, both to recognize, you may find yourself there, which I'd love to see, but you also have the opportunity to recognize others, which is an incredibly important component. So I have read through a number, and I'll leave you to go through those on your own going forward. Thank you to all who took the time to put these up. I know this is we are not blessed with a lot of extra time. I also would like to extend my personal thanks to Dr. Hoda and Ms. Elder. They've been answering the majority of questions at these open forums and have made themselves available for your questions despite many competing demands. Before handing it over to Jill, I wanted to chat with you about an area that I know is concerning to us all, and I hope I'll give you some confidence. I have greater confidence after getting this information. So I'm very proud to say, thanks to the sourcing team and the team that so many people have worked towards getting adequate supplies on hand, I can confirm that we have 30-day supply or greater in all areas of PPE. There are two areas where we're struggling just slightly. One is the hand sanitizer fluids that are mounted on the walls. And while we have hand sanitizer, it's not easy to get this at this time. So we're actually looking at how we'd alternately source this, including working with some providers who can take alcohol and gel it. Filling those units, because of the types of bags they come in, are challenging, but I want you to know that we do have a strategy. We have about a week's supply of that. And the only other area where we don't have a 30-day supply is in wipes. And we are, again, working through that one, alternate sourcing for wipes, and I'm confident both of those areas we have a week to 10 days supply. I'm confident that we will have adequate supply. So I want to reinforce to you, many of you who are very anxious about will we run out, and talk to you about the strategy we've been using and will continue to use with a true abundance of caution. So category A, we have a 30-day supply based on our current utilization rate. And I have to underline current utilization rate. It's very important that if that changes dramatically, we'll have to revisit that. So I know you are anxious about the concept of conservation, but it is so important that we truly be evaluating when and where and how what we actually need so that it is there when we need it. But I want to assure you that it will be if we're prudent and continue using resources as we have to date. The second is we have a very substantial amount of donations that have been given, and we also have a smaller but important supply of recently expired resources, including masks. This would be a phase B. I don't think we'll be getting into phase B. I'm optimistic that we'll stay with phase A because we are seeing deliveries now occurring. But in the event, we'd first go to our donations, which are large, and I want to recognize our donors. And then secondly, we'd be looking at recently expired, like within the last month, things like N95 masks. We would not be deploying those without working carefully with both the science of expired products and our bargaining units and Ontario Health. So again, it's a backup. And the third backup that I hope we'll never have to use is that we are now starting the collection for reprocessing, particularly of masks and 95 masks. And this is truly a last resort, but I believe it's prudent for us to be both experimenting with and having those on hand in the unlikely event we need them. I would hate to ever find UHN in a position where it wished it had done that, as others have. But I also want to reinforce, I know there were strong feelings about this. Our role will be to both begin the process, learn from the process, test the product, and evaluate that it is truly safe in the unlikely event that we need it. Let me just pause there because I think John Granton is on the line and he might want to add a couple of comments to this before we get into questions. John, anything you'd like to add?
No, I think you summarized it very nicely, Kevin, and I think we just want to make sure that we have everything lined up to make sure that we never run out of supplies. And so what we're seeing is a simultaneous execution of what we do day to day, expanding what we do today, ensuring that our supplies are secure and that they're accessible and that we use them rationally, and that should protect us. But in the event we have a greater surge, we want to make sure there's a plan B and plan C in place to make sure we always have product available for our frontline workers.
Yeah. Agreed. I also want to mention Susie Hota shared with me that there is already a Toronto Region working group looking at reprocessing, and there now is also a provincial working group. Again, we are all looking at that as the last resort, but again, prudency would suggest we will never allow a UHN member of Team UHN to be put in a position where they don't have personal protective equipment in order to treat a patient. I want to truly underline that. We will never allow you to be put in a position to treat a patient where you don't have adequate PPE. If that requires us to share with ambulance services and others that we can't treat any more patients, then that is exactly what we'll do. We cannot and will not put you in harm's way without safe personal protective equipment. So let me, at that point, turn over to Jill.
Okay, so Kevin, the one thing maybe you want to comment, I think we we had encouraging news today about the U.S. border and supplies.
Yes, so I want to thank our political friends, the Deputy Prime Minister, Chrystia Freeland, the Minister of Procurement, Minister Anita Anand, our Premier, who's been out there, as you know, duking it out for us. We had confirmation today that 3M will be able to ship to Canada and Mexico. We also have 3M lined up on the international shipments that Canada has arranged and UHN has participated in order to test that equipment. We know that there is the risk of counterfeit product, so I'm very encouraged that that will flow and flow more quickly. And again, I want to really take my hat off to both our provincial, federal, and municipal political leaders, Mayor Tory, Premier Ford, and Prime Minister Trudeau and Deputy Prime Minister Freeland have been fantastic to work with through this process, and their work is really bearing fruit to get the supplies we need.
I think it's also fair to say that UHN has played a fair part in that, Mark Toppings in particular.
Yeah, Mark has had many sleepless nights, the 3 a.m. Lawyers' calls back and forth for astoundingly large amounts of money, purchasing tens and hundreds of millions of products. And Mark and the legal team, the procurement people, the people from the ministry involved in procurement, the people, some of our colleagues from Unity Health as well, have really come together, and the singular focus is getting PPE so clinicians and patients can be safe. And we are almost over the line, so I'm really, really grateful, and as I know you are.
Yeah, I think we're not talking numbers until they're in the warehouse,
Right.
but it is very encouraging. So we have on the screen the people who are with us today who are able to answer questions, and I'll be calling them up either on the phone or to the microphone. After each open forum, we send out a recap of the top questions that we answered, as well as a feedback survey, and we're continuing to group questions into a few themes, and then answer top voted questions. So today's themes include personal protective equipment and guidelines and reprocessing, which I think, Kevin, you've just addressed. I don't know, I think when we get into the questions, we'll probably be asking Susie to take part. Supply and capacity is another one, and physical distancing. But the first thing I'm going to do is turn the floor over to Marnie Ascaf, who is on the phone, Senior Vice President and Executive Lead of Princess Margaret, to give an overview of UHN's capacity plan, because there is a group of people, and Marnie, you probably want to talk about who they are, working on our capacity plan for patients.
Can you hear me okay?
Yes.
So there's two documents or two areas of focus that I want to share with folks today. So one is our inpatient bed capacity plan, and that is what is up on the screen now, and then later we'll go over the surge criteria. So as Jill mentioned, we have a broad inpatient working group with representation across the network. And we've developed a capacity plan for all 4 of our sites. So the plan is really based on the principle of organizing patients according to their known COVID positive, that is COVID negative, or patients under investigation, which we refer to, or which is known as PUI. So that really organizing to ensure that we can decant both the ED and the ICU as the highest priority during this period of time. So each site has developed a conversion plan for their units, and units will be converted as volumes increase. In addition to this, we're also exploring the use of unconventional spaces that could be used for beds, such as lounges, previous inpatient units, types of unconventional spaces should our volume actually exceed our total physical capacity. And in order to create capacity, and many of you may already know this, we've significantly reduced our clinical volumes, so thank you to everyone for your work on that. Princess Margaret and Toronto Rehab have played a key role in assisting both TG and TW to create capacity. Toronto Rehab has created an additional 80 beds, and that's some at UC and others at the Bickle site. And this, in turn, has helped decrease our our acute. We've dropped from about 90 down to low 30s, so that's been fantastic. Princess Margaret is actively opening 40 beds, and that's really to assist in the care of oncology patients that are currently at the Toronto General site. And as a result of all of this work, including the reduced volumes, we currently have over 550 beds available at this point in time across our various sites. And so I won't walk through the specifics on the document. I think everything that I've sort of mentioned at a high level is there in detail. I will mention, because this did come up in one of the Slido questions about the ICU. Thank you for that, because we have recognized the fact that even within our ICU, there's a provincial critical care working group, but within our ICU work, that we have designated sort of progression of COVID patients, starting with the med-surg ICU at the Toronto General and the ICU, obviously, at the Toronto Western site. And just to close out on this, just want to acknowledge both Brenda Kennefick and Anil Chopra, who chaired the inpatient working group, and everybody who contributed to that. So if we could now pull up the search criteria document. This is up on the screen. I'll talk about it while we wait for it to come up, in case it doesn't come up. This is a document that goes alongside with the capacity planning document, and this is really organizing the site, or organizing our criteria around 5 different surge levels. There we go. So the pandemic surge levels, and this is as a result of the critical care work that was done provincially, has different levels from blue to green, yellow, red to gray at the worst. And we set our own UHN triggers, and those triggers are based on capacity. They're based on the rate of COVID change that we are seeing within the organization, and they're based on staffing. And in that, then we worked with each of the different groups and to set what we think appropriate triggers would be. We've also done an extensive amount of work through Joy Richards and her team, led by Karen Martin, around staffing plans. And what those staffing plans are is they look at our current ratios that we have today, and then they switch our models of care more to team models, and looking at, as we switch from green to yellow or yellow red, what do we need to do with our staffing levels to be able to accommodate that additional volume and the additional beds that we would be opening. That document is literally just completed and will be shared very soon with everyone, so that units are familiar with what would be expected should we need to surge up. And then just finally, I'll mention that we have just this week instituted daily calls with our sites, where each site then in the morning has a call, and they look at what surge level they believe that they are at. Then we have a UHN-wide call, where we then have a conversation as a broader group, including our diagnostics and support services and facilities and others, to look at what is the surge level we believe we are at for UHN as a whole. Our redeployment groups, both physician and staffing, are part of that. And depending on what level then we are at for the organization, then dictate the actions that would follow. So that's it in a nutshell. We will post these documents on the COVID site. And just mention that these have been fairly fluid, so as we gain experience with them, we are updating and changing the documents. So happy to post it, but just know that it's constantly evolving. So I think I'll stop there, Jill.
Okay, I think Kevin has a couple of comments he wants to make, and I'm going to invite Diana to come up to the table for the next topic.
So first, Marnie, to you and your team, thank you for this excellent work, and I know it's dovetailing nicely with the work that's being done provincially so that we are all operating with similar platform. I also want to recognize an oversight on my part. A number of you have emailed me about the COVID positive area at Princess Margaret when I sent out my previous communication. So I want to correct that and say thank you to the colleagues at Princess Margaret who are ramping that up. Just three or four other quick updates before Diana starts. One area that's come up, or one issue that's come up that's incredibly important. As we all know, UHN is Canada's largest research hospital, and research around COVID could never be more important than it is right now. The researchers who are continuing to work on site at UHN at this time are uniquely focused on COVID research so that we can really understand this disease and hopefully beat it quickly. In a couple of environments, researchers or research assistants or research colleagues who visited clinical environments doing research on COVID it's been suggested that they wouldn't be entitled to PPE. I want to clarify, nothing could be further from the truth. All of Team UHN, who are taking important roles in trying to beat this virus, are absolutely entitled to PPE, so please make sure that in your units it's clear and well known that if you're a researcher working on site now, you are focused on COVID, and you not only should have, you must have equal access to PPE as any other member of the team. So we'll make that very clear. Secondly, I also want to say recently, more information and more concern around drug supplies. So we've been working both with the provincial government through the ministry and the federal government around the top 10 drugs, particularly related to those who require intensive care, have come to the fore. And I want to thank Jen and the team in pharmacy and more broadly and Emily, of course, across the organization as we begin thinking about what drugs are essential, what if we have short supplies, how will we alternate that, and what again is the conservation method. Some will be advantaged by our dramatic downturn of scheduled or elective activity. Two last comments. One around thanks to Joe Cafasso and Neil Ferguson. As you know, there's been a lot of dialogue in the media about adequate numbers of ventilators. And while we don't actually have the luxury of ordering and receiving in a timely fashion the ventilators we'd normally work with. So a number of very creative solutions have come to the table, and Joe and Neil and their teams are evaluating each and every one of these and looking at in an unfortunate situation, if we didn't have adequate supply of our normal ventilators or anesthesia machines, what would be the best alternative to use? And that's work being done provincially, and I'm sure will be shared nationally. And last but certainly not least, thanks to Brian Hodges and Rue Taggart, who've done a lot of work on health professional, and now perhaps even expanding beyond health professional, redeployment and training. And I know there's been a great deal of discussion about how that can go from being a provincial resource and then a national resource. And I just want to remind people who are thinking about redeployment or would like to gain some additional skills to go to their respective websites, which will be posted in my next communication. So with that, let me turn it over to Diana.
Thanks, Kevin. So I've been asked to talk a little bit about the redeployment process and the redeployment center because we've been getting lots of questions about that. But before I start, I really want to acknowledge that for everybody that we are working in strange times and that we're all coping with stress and uncertainty. We're all worried about our families, our friends, and our communities, and ourselves. And we're also all being asked to take on work that's unfamiliar to us and to work in ways that we've not worked in before. So we're all learning as we do, and this can be really uncomfortable. And I think that's a great introduction to redeployment because that's exactly what happens through the redeployment process. Individuals are asked to take on work and take on new skills that they haven't traditionally done in the past. And I just want to really acknowledge that that is difficult, but we're really all in this together. So I'm going to talk about UHN's redeployment process and the principles that we are using to make difficult decisions and to ensure that we have the right staff in the right place at the right time and where we most need them in order to care for our patients. I first want to thank everyone for being flexible and demonstrating your commitment to patients and Team UHN, and for staying calm and focused, for the most part, as we move through COVID-19, and especially to those of you who have already been redeployed and who've really stepped up in the face of this emergency situation. And as Marnie has described through the clinical protocols, some frontline healthcare providers have already been redeployed as patient volumes have decreased, and other frontline workers are being trained to work in critical areas like the ICU and the emergency department, areas where we anticipate that we will be expanding, and also new units that will need to be staffed. On the non-clinical side, we've had new roles like the respite center and also roles within the redeployment center and our door screeners, which are invaluable to us at this time, where we've needed and do need over 110 individuals every day to cover the entrances at all of our sites in 2 shifts. So thank you to those of you who've stepped forward to take on that task. I think as we've all been emphasizing, everyone is essential, and we should all expect to be contributing to address this crisis, either by doing COVID-related work in our departments, that is happening right now, doing essential services, or by being redeployed either partially or fully for the duration of this crisis. So why have we set up the redeployment center, and what is it? In the same way that our executive have organized around a command center to direct the pandemic effort at UHN, the redeployment center is part of that response and has been activated to manage our shifting workforce priorities. So the redeployment center is the point of entry for receiving and assessing prioritized staff requests across the organization. There's a matching process that happens within the redeployment center, where staff are sent to areas of need that will support our delivery of clinical care. Actually, on the first, we need to go back to the principles. Okay, so here are the principles that we are using to deploy staff within the redeployment center. We are focusing on ensuring that we are maintaining our UHN values throughout this process. Safety is our primary value, and as Kevin has alluded to, we will ensure that no one is placed in an unsafe deployed situation, that you will receive the appropriate training or orientation and equipment so that you can be successful and safe in that new role. Patient care is obviously our priority, so individuals will be shifting to support those activities. We want to be responsive to needs. The needs change on a daily basis, so we reassess on a daily basis where staff is needed through the requests that come into the redeployment center. We also want to ensure that there is an equitable workload, and that's why we need everyone. We need to ensure that all of us are participating in this response so that individuals are not carrying more of the burden than others. We're asking for flexibility. This is a 24/7 operation. Some of us have not, have been working core hours around 9 to 5, et cetera, and we're asking that you consider and be ready to work outside of your regularly scheduled shifts, particularly on evenings or weekends or early in the morning. We will be endeavoring to ensure that the best suited individuals are redeployed to specific roles. Sometimes it means that individuals who don't have 100% of the skills need to be redeployed, but we will be ensuring that those individuals are supported so that they can work appropriately. And again, as we were saying, we're going to ensure that you're prepared for your new role. And at this time, this is a question that I've been getting a lot, the question around, is redeployment mandatory? I think that it's incumbent upon all of us to acknowledge that we are in an emergency situation, and at this point, redeployment is mandatory. So if you're assigned a redeployed role or redeployed shift, the expectation is that you will be completing that task.
Thanks very much, Diana. So we're going to move on to the three big topics from what we heard from the last forum. Susie, I'm going to come to you first. So if you can unmute your phone or your microphone. And I think it's particularly relevant that Kevin talked about this as Plan C. This is the last thing that we want to do, but that we are thinking about it, and Susie's thinking about it. So the question is, I heard UHN is collecting used N95 masks to be sterilized and reused. Can you please explain this process and how these masks would be proven still safe? How would they not be broken down during sterilization, making them ineffective for use? And how would the seal be the same quality after multiple uses? So Susie, can you talk a bit about the work that you're doing?
Sure. And actually, this is the work that I fully acknowledge involves a large number of people, including our medical device reprocessing department and many others who've been collecting information on how we could do this if we absolutely needed to, the most effective way and as safe as possible. So again, I wanted to emphasize that the reuse and reprocessing and reuse of N95 respirators is one of many different conservation strategies that we're exploring, and it is something that we would reserve as more of a last resort measure if we absolutely needed to. So while we have the time, we think it's important to be looking at how we can do this the best way possible. So we're really sort of playing around with the different processes, doing the research as to what other institutions have already done to see how you can safely apply reprocessing of N95 respirators, how you can make sure that it's going to be effective against, the virus that could contaminate the surface, as well as other bugs that can get on the N95 respirators, as well as keep the integrity of the respirators intact, and finally, not affect the fit. So all of the questions that this individual has pointed out are really important questions that we need to feel comfortable with if we're going to be exploring this option. So like I had mentioned, many other parties have been looking at this, and we're trying to share the information that we learn in different institutions that are trialing this, and that way we can do it more efficiently.
Okay, thanks, Susie. I will say that earlier on we did address the first question about clinical research staff being eligible or receiving masks. I think Kevin was very strong on that point. The third question, is mobilizing a COVID-positive patient considered an aerosol-generating medical procedure? Oftentimes, our patients do cough productively when we are getting them up. In these cases, should we wear N95 masks to be safe? So I'm looking around the room. It could be Susie, it could be Joy, or John Granton is on the line. John, are you there?
Maybe John had to
I think
leave.
he might have left us.
So it's Susie. I'm happy to
Okay.
take this one as well. So mobilizing a patient during physiotherapy or other therapies is generally not considered an aerosol-generating medical procedure. It is true that sometimes people do cough, but coughs generate large droplets primarily. There can be some smaller droplets as well that are generated, but a mask and face shield is generally adequate to protect against the virus during those activities.
Okay. Question 4. I am deeply concerned about PPE. We should make effort to use it appropriately so that we don't run into a shortage and need to provide care unprotected. What should I do if I see staff taking PPE for personal use? What should I do when I see staff overdoing it, double masking or a hairnet? Maybe, Kevin, you want to talk to that.
Yeah, let me start, and for colleagues on the line, Susie particularly, please feel free to join in. I think those things are occurring out of fear, and I think the best thing we can do is help people understand why that is neither necessary nor helpful. And I think the biggest worry we all should have in situations like that is, will it leave someone else without adequate coverage, including the person who may be undertaking that overutilization in the case of double masking, which we know actually doesn't work. So I think 3 things. 1, if you feel comfortable chatting with the person about why they're doing that, great. If you don't, I think talking to your manager would be the next best step. And then I think we need to also get out there, and we will be doing a better job working with unit directors and on-the-ground managers and clinical leads so that people are really well educated about why that is neither helpful nor more protective. I know it's hard to believe at times of anxiety like this, and where evidence is changing and advice is changing. We recognize the advice from our own leader from the Federal Public Health Agency has made some recent changes. But again, I think it has to come back to a balance of conservation with personal protection. And certainly personal protection comes down to making the choice of PPE when the clinical conditions indicate it, but overutilization is something that we really have to combat. Susie, anything you want to add?
No, I think that I would just echo what you mentioned and the strategies people can use to try and address these concerns. I would also say that our infection prevention and control team members would happily help with reminding people what measures are necessary and what would be not really advisable, like double masking.
And I think, Kevin, the last one is for you in this topic. It feels like UHN is deflecting all responsibility onto staff. So if staff gets sick, it is our own individual fault, mistake with PCRA or doffing, or we got it from the community. But also, if we run out of PPE, it's our individual fault for inappropriate use of PPE.
So I have to confess that when I read this question, it was one of those ones where the hair on the back of my neck stood up, because I just don't get that you'd actually believe that anyone at UHN, starting with me and the board, would ever want to deflect responsibility. So you are part of a team. We want to support every member of it. I hope you'll feel through these processes and all of the communication, what we've been trying to do is share information. God forbid, but if any staff do get sick, we're not looking for fault, we're looking for protection. And I can assure you that the first issue will be in caring for you as a colleague, should you choose to get your care here and need it. Unfortunately, much of what we've said, and you've interpreted it as deflection, which it certainly is not intended to be, is fact that many people, many healthcare providers, unfortunately pick up a virus when doffing equipment. So what have we done about that? Well, we've put in place observers, we've put in place more training, we've put in place e-learning, and it is actually a fact that people are lulled into a false sense of security by wearing personal protective equipment. I can't tell you how many people I've seen walking around our hospital sites wearing masks but not observing social distance or physical distancing. A mask does not suggest you shouldn't observe physical distancing. So I really, again, want to reinforce the concept that you're safe once you've got some of these materials on is incorrect. And but should you get ill, obviously we're going to be there to support you 100%. Running out of PPE, it's not individual fault, but I have to tell you, we saw our numbers go up in the early days 8-fold before we'd seen a single patient. And so that was concerning, and it's important that we be transparent about that kind of utilization when we're worried about those who will be doing aerosolized procedures in the future. As I said, I think we're in a much better position than we were. I'm grateful to many people for helping us build a stock. But the world is concerned about PPE as we have to be. So I get the question is probably one out of fear. But I hope you'd never feel like we're deflecting anything other than trying to be supportive of staff.
I wonder if this doesn't come from the language around the clinical evaluation of each patient, that each clinical profession has a responsibility to evaluate patients before they go into the room. Not because we're deflecting responsibility, but because that's a professional responsibility.
Right. Yeah, that's a good point, Jill. So as you know, there's been a lot of discussion, and it's not, UHN can't act unilaterally, but there's been a lot of discussion with ONA and our other bargaining unit partners around what does it mean and what is want and need and how do we balance those. And I think the language really does reflect that as clinicians, one needs to make a personal judgment. As clinicians, you're also science-based. You've been trained in the principles of science. And so we also need to say, is there similarity in utilization, or are we outriders relative to our peers at a time when everyone is scrambling to be fairly protected? So, you know what, I wish I had the simple answer. I think it comes back to, in your clinical judgment, if that is the right thing to do. And if asked by someone who had to validate why our utilization looked different, do you have a legitimate clinical rationale for using the personal protective equipment you've chosen? And if you do, then you'll have 100% support from us.
Okay, now we move on to supply and capacity, and I actually, the next question is about the modeling, so I'm going to ask you to answer it. Based on the COVID-19 modeling presentation released by the province on April the 3rd, the worst-case scenario modeling predicts that for Ontario, ICU capacity for COVID-19, the need will exceed available capacity on approximately April the 13th or 14th, even with an additional 900 ICU beds. Slide 14 in the presentation. What is UHN's plan?
So first I want to thank the various modeling groups, particularly Beate Saunders and her group, who've done remarkable work. And I have to remind people, as I'm reminded frequently, they are models. They are not fact. They are predictions, and most predictions have various degrees of error. What we have done since looking at the modeling is increased the potential number of both general beds, med-surg beds, as well as ICU beds. We've also put in place, working with EMAT, the Emergency Measures Group, the potential for a field hospital should it be required. As I mentioned at the beginning of this, we also have groups looking at alternatives to our traditional ventilators, which we know ventilator support is a rate-limiting factor in some cases, and drugs. So all of those things are occurring. I believe that in the event that we surge past the anticipated 900, that we do have a plan in place. My anxiety, frankly, about the plan in place, as I know Dr. Richards and Dr. Hodges have been working on, is staffing. That how will we staff, and it will not be in the norm. It would be looking at a very different kind of ratio in the event that we see the kind of peak that the worst case scenario suggests. So we're going to continue to work at that, but there will be the physical capacity for us to address that, and we believe that there will be both drug and ventilator support. Leave it with us around the management of patients through more creative work, interdisciplinary teams.
The next question, President Trump, this question would have come in a while ago, so President Trump has reversed that, and they will be sharing masks from 3M to Canada. But what is our current supply within UHN? And please don't say adequate. I want an accurate number. We as Team UHN deserve to know the exact number. Second, where are we getting the masks from? So
we have in excess of a 30-day supply of N95 masks, which we are one of the more privileged hospitals in the province, thanks to the historical work of our pandemic planning and the great purchasing professionals that work here and the clinical managers. The only caution I should add with that is there are many hospitals that don't, and the minister has indicated that she does have the power to move stock. So my only suggestion on that one is I'm confident that UHN has more than adequate supply. My worry, and we would want to support our colleagues, of course, is that if others run out, they may look to places like UHN, who've been well and prudently supplied, to help people make it through, as we would hope others would do for us. But at the moment, and second, where are we getting our masks from? With the change yesterday, I don't know if President Trump actually made the statement, but I believe officials in his government have, who have said we will see 3M masks continue to flow. There's 500,000, I believe, destined for Canada in the next day or so. In addition to that, we're seeing them from China, Thailand, and other Asian countries in particular. Just so you have confidence, all of our processes will allow us to validate that the masks are produced by who they suggest they're produced by, in this case 3M. There's a process that allows us to both evaluate them, work with 3M, and work with an independent evaluation company to ensure that random samples actually function to the specification. In the case of N95, that they function at an N95 level. So I think you should have confidence in those areas. The only two, as I mentioned earlier, where we're a bit short, wipes, which I think we'll figure out an alternative on, and some hand sanitizer, which we already have some alternatives, though it may not be the wall-mounted model that we're used to.
The next one, Kevin, I think is probably for you and for Susie. Is UHN considering securing and/or administering serology tests among staff in order to determine immunity? Given the global PPE shortage, serology testing could have significant implications in redeployment of immune staff to high-risk and frontline areas. I guess one of the things, first of all, Susie, if you want to comment on whether we actually know whether having come through COVID-19 gives you immunity.
Yes, so I think a lot of this is still fairly exploratory right now, and we don't really know when people mount an effective immune response, and on average at least, and for how long that would last. I do know that our lab group is looking into different serology type tests, and that this could help us, in the long run, as is mentioned here. It'll also help us have a better sense of overall how many people have been infected.
Yeah. Marnie, I think you're not on mute. Let me add to Susie's comment. So 3 things. One, we had, I think, a very interesting number of conversations yesterday. Dr. Waters, as our EVP for Science and Research, has been working with a number of investigators. Dr. Naylor, I know, President Emeritus of the University of Toronto, has also been working in this area, as has the Public Health Agency of Canada. So we absolutely are considering it through our research endeavors. You'll also know that there's a clinical trial led by a gentleman named Don Arnold out of McMaster in looking at serum testing, so basically retrieving blood and plasma from recovered patients and then investigating how that might be applied. That actually dates back to the flu of 1918, so it's not new research, but it's great research and pragmatic research. So in every area, we're also looking at the kind of testing that is important for us. Not only do you have the virus actively, but have you had it? And of course, there is a hypothesis yet to be proven that there are healthcare workers who've had it, were asymptomatic, no longer have it, and may have built up an immunity. It would be wonderful if we could identify who those are, because they would be the least at-risk providers. So we are very active as Canada's largest research hospital in this space. And I would say every one of these questions has got a research team on it, and we'll be aggressive in pushing it forward.
The last question in this category, we are hearing from our American colleagues that they are running out of everything: propofol, muscle relaxants, dialysis equipment. What is being done to ensure adequate medical supplies other than PPE?
So great question. I think when you're hearing from your American colleagues, it's probably mostly centered in New York, New Jersey, and Connecticut. And the United States has now begun releasing its emergency supplies from across the country. We see, as an example, California redeploying. We have, I think, a very different strategy. Number one, a different supply chain, and number two, a different stockpile. So based on the numbers that we've been anticipating, and since this process has begun, along with the dramatic turn down of scheduled or elective care, we believe that we are being prudent in the use of these drugs and other supplies. We are now working pan-nationally and internationally. There's also a number of clinical groups looking at alternatives. So in the event that a normally used drug was no longer available, are there older drugs or drug combinations that could be used? And our clinical pharmacologists and pharmacy leaders are looking at all that work as we speak. So at the moment, I think we're reasonably confident that we're well served on that one to date.
So the last category is physical distancing. I'm not sure if Rebecca's on the line.
Rebecca, are you with us? Oh, we can.
Okay, we'll have a stab at this. Once the hotel accommodation process is finalized, which staff members will be eligible for this? Will this only be available to full-time nurses and staff or to all staff?
So I certainly think that for those staff who have some degree of risk, then of course it wouldn't just be to full-time nurses, but any staff who would be involved in direct patient care or might come in contact with an environment where infection control could be an issue. But let me make sure that we send that out to you as it is finalized, but it is not exclusively reserved for nurses or physicians or any other provider group, but any who might potentially be at risk. And obviously you could talk with your manager or chief or program medical director if you felt that you should be considered in this, and we would expedite that if they agreed.
The next question, and probably the last one, input from Susie and Kevin. Some colleagues are being disrespectful to those who take the TTC to work and demanding why they do so and put everyone else at risk. This is not fair and needs to be addressed. Can you comment on the risks of taking public transit during this time and remind people to be respectful to each other? Susie, I think one of the reasons you're on here is because you do take the TTC to work. So can you talk about the risks involved, and then Kevin, maybe about the disrespect?
Yeah, so, I think it's safe to take the TTC if you're able to maintain that physical distancing. And, that might be dependent somewhat on the hours that you're taking the TTC, what your route is, et cetera, whether you're taking a bus versus, the subway versus a streetcar. It does have to be an individual judgment at this point in time. I personally have not experienced these issues, but I can see that this is something that might be more challenging depending on what your situation is. And at some point in time, you'll have to make that judgment as to whether it's still something you'd like to do. But I think the rest of the question is sort of pertaining to people's reactions and the way that they're responding to this. And it speaks more to the original points of this forum, which are about being respectful with one another and civil, and having a useful discussion about it rather than trying to put people on the spot and make them feel bad about it.
Yeah, so I agree. I think the other piece is clearly whenever we can do social distancing anywhere, we should. I think there are a number of other initiatives underway about how people can or might consider getting to work. And certainly no one who's practicing good hygiene, public health hygiene, and social distancing or physical distancing should in any way, shape, or form be harmed by this. I know you, like I, will be heard Dr. Tam talk about people who chose to wear non-medical masks in environments like that. I think a lot of us are still trying to process what that means. Is it helpful or not helpful? But there are many strategies I think you can use, and taking the TTC is not a higher risk than any other social engagement that occurs. No more so, frankly, than two people walking without physical distancing here at UHN, and we have to be just as vigilant about that. But I know we'll all try to be respectful, and many of us have no alternative to the TTC. I also appreciate that.
Kevin, the last part of the question talks about the displaced homeless, and maybe you want to talk a bit about what we're trying to do in the city.
Yeah, as you know, some months ago, UHN, over almost 2 years ago, UHN made a decision to jump aggressively into looking at the social determinants of health and social medicine. And so we've been working very diligently with the city through Toronto Public Health and with a number of other providers, including Unity Health, looking at if we could find an environment for the underhoused who are either positive or potentially positive. It's taken an inordinately long time, and I think there's been a lot of frustration. I want to thank Dr. Hoda, who's played a big role in getting this initial site up and open from an IPAC perspective. And then, of course, we're now struggling a little bit with ensuring that people working in that environment, which is a non-medical environment, it would not be a clinical environment, but a shelter-like environment, have adequate PPE. So I believe we are down to the last one or two issues to resolve, and a couple of hundred rooms are coming online. In addition to that, Tess Romaine, who's the regional lead for Ontario Health, has been looking at other options, and we've also put some options forward of potential sites at UHN, but it's a very important issue. We know marginalized people, disadvantaged people, homeless people, and the least economically advantaged are at the highest risk for this virus, so we want to be very attentive to that. I also want to recognize that it's been very hard in the emergency room for people who are awaiting a result, who are underhoused. So we're working diligently to look at where that waiting period might occur, be it even for a few hours. The emergency rooms are far less than ideal for a number of people to wait for the results of a test.
Okay, we don't have a lot of time, but I am going to turn to the questions on Slido. So the first one is for Susie. Question for Dr. Hoda. What is the best way to decontaminate when getting home from work? I change clothes before I leave, but should I be showering immediately upon return to home? Do my clothes need to be washed that day, or is it okay to put them in the laundry hamper for a few days? Any other suggestions? Thank you.
So, I mean, my personal view is it's most important that you wash your hands immediately when you come into your home, because that's where you would have, touched and potentially contaminated part of your body. If you feel comfortable taking a shower right away, by all means do that. In terms of what to do with your clothes, our best knowledge says that the virus generally doesn't live more than a few days on most surfaces. So it is probably okay for you to leave your soiled clothes or used clothes in the hamper, as long as you're not going to be touching it and manipulating it. I think that's where people need to be a little bit more careful, is how you're actually handling your laundry and making sure that you wash your hands after you put the laundry into your washing machine and gone through the cycle.
Okay, thanks. Next question. So, based on currently available data, 3M does not recommend or support attempts to sanitize, disinfect the mask. So, Kevin, maybe talk about that.
Yeah, so I'm searching for words to be politically correct on this one, and I'm probably going to be unsuccessful. So, you know what, if you sell masks and you like to sell lots of masks in normal times, I think people would say, of course, providers want to sell more product and sanitize. If the alternative is selling less product, why would you encourage us to sterilize these masks? We're not using this as a principal approach. We're using this as a last point of recovery if needed. But from all that I've seen, while 3M has not historically supported that, 3M is working with us to ensure that in a sterilization process, it would not break down the mask. In other environments, we've heard using a hydrogen peroxide approach, 3 to 5 time reutilization, again at UHN. With our experimentation of this, it would be fewer times than that, I believe. But again, I just want to reinforce that is not something that I believe we'll be facing unless there's a radical challenge of supply chain or an even much greater surge in this illness than we've been seeing or have seen in other jurisdictions. So, but I can assure you that if we were ever in a situation like that, it would be only after those masks were carefully tested that we would say that they were appropriate for utilization and fully sterilized.
The next question is about an email that was sent to all users from Emma, and it was about the paying of research staff. There's questions about the tone and whether these individuals can expect to be laid off. This was totally inappropriate and goes against everything that has been discussed on open forums. I'm not sure if Emma's on the line or
Yeah, Emma, are you with? Yep. Do you want to comment on this one?
Yep. Sure. So most of you would have seen Kevin's email yesterday with regards to the fact that we have been able to extend our sick time to the end of April for all people that normally are not eligible for sick time, like, for example, part-timers. And that's great. However, that does not address many other situations that we have in the hospital. So, for example, in research, I'm aware that some research has been suspended and some employees are available for redeployment. However, we do have some employees that, due to their normal work being stopped for now, are really not working. So my intention is to work with Brad to support research staff by reviewing several options, including redeployment. The email, which unfortunately, went to all users, as you know, that was not my intent, and I apologize for that. my email was really simply asking Brad to work with me on these options. We have already began discussing them because research leadership needs to do that. And the email was really simply just inviting Brad Waters to get in touch with me in order to discuss various options with regards to people that are not working right now in their normal work. Unfortunately, some people read more into it than was in it, and I assume it's because of the times that we're in and the anxiety level. But really, that was my only intent. And again, I apologize that this went out because people obviously read more into it than the email really said.
Thanks, Emma. I think Brad's here with us and probably would like to add something.
Sure. So, I think the question that came up represents the anxiety that's out there in research. There certainly is a lot of that. And I've been working very closely with Emma and Diana and Lisa and our human resources colleagues on looking at all possible options to support our staff. And let me just say that, the support for our research staff and the assurance of maintaining the important jobs that everyone has in research is my number one concern right now. And we're looking at all possible options. That includes redeployment, which is a good option for many of us. We've received assurance from most of our funders, those that provide grants, the federal government who provides grants, many of their charities who provide grants, that they're fine with us continuing to pay staff while research is suspended. There is some lost revenue from contracts with industry and pharmaceutical companies and clinical trials that are stopped, and we're working very hard on solutions for those too, including advocating at the federal government. And this is not just us here at UHN, my colleagues at the Tasman hospitals across Ontario and even across Canada, Healthcare Can, and other organizations are collectively all working very hard with the federal government. They have been responsive, and we're looking towards, potential assistance from them. So, we're working hard on this. This is, as I said, a huge priority for us, and our staff is absolutely critical, not only for when we come out of this, but right now in dealing with the research that's ongoing with COVID-19.
Thanks, Brad. So I'm going to give the final word to Kevin because we're 2 minutes over.
Okay, I'll hurry up. So one on the last topic, this has gone all the way up to our board chair, Brian Porter, who I know has personally reached out to many leaders of the federal government in the importance and advocacy as Canada's largest research hospital, the importance of this. And to the overall question, I just also want to remind us all, in times like these, when people work very, very closely together, we sometimes send terse emails because we know each other well, and that when I know Jill and I did one recently to Jill that I got in trouble
Kevin.
for, and you know what? It was not intended for mass consumption, but Jill and I work so closely together that we're not easily put off by rapid language and sometimes quick retorts, and we have a lot of fun doing that. So just remind us that when you work very closely with people, sometimes your responses are out of context to another, might seem unusual, but when you're doing that, it's just the speed of the issue, and I know that's what happened here, and all intents were for the good of the organization and the good of the research team. Let me close a couple minutes over by where I always do, a sincere thank you to all members of Team UHN. You're doing amazing work. The Premier actually asked me, and Her Honor, the Lieutenant Governor, called me yesterday, said, would you please convey to everyone at UHN the great thanks of the people of Ontario, and she represents Her Majesty the Queen. She particularly wanted to shout out to all of you providing care, but she asked me to especially thank those who support those who provide care in food services, in housekeeping, in a number of areas that don't always get the accolades who deserve them. So on behalf of Her Honor, let me also ask your other colleagues to close by thanking all of you who make the place run each and every day. Thank you.